We're going to talk about evaluating the quality of patient engagement, and I've put my own stamp on this. And so you see here there's a table that talks about the different levels of patient engagement in the healthcare system. You've seen this. I'm not going to spend too much time on it, but just to show you that we can go from information to partnership to co-construction, and that is really what we want to focus on in this presentation today. And it can be done not just in care, but also in terms of organization for improving the quality and the quality of care. And so the focus of my presentation will be really around the last column of the table, which is the one that speaks of partnership. Am I going too quickly? One of my screens is not the same as the other one. So the tree here that I wanted to show you, and so the idea here is that we are all, well, before we were talking about patient citizens, and as citizen patients, we are all partners in the healthcare system. And this, how does this translate on the ground to have a recognition of the experience and knowledge of people? That is really the basis of everything. The second point is to be considered as a full member of the team. And the third point is that decisions beyond shared decision making we were talking about is the decisions are oriented around the project and the quality of life of the people. So there's people who want to use the experience they've had in their care, and so they can do that by training others, so they become trainers, or they become resource patients, and so and also research patients that allow us to make research evolve. So to help with the structuring of these patients, we have patients that are coaches, that are much more experienced and become coaches and can help guide them in their process and their career as a patient, as what we say now. So is there
Donc, la façon dont j'ai
So the way I structured the presentation is to really talk about the different levels of the tree. So to really talk about the patient and resources in terms of care and what the literature shows us and what's done at the University of Montreal. So these resource patients, patient partners can intervene because they want to use their experience and with other people who've had the same kind of experience. And so if we look at this, there's really a lot of oncology and mental health, but there are a lot of activities in other areas. And so what we find is that, especially in oncology, the patients really allow us to help patients that are newly diagnosed, that have just been diagnosed, and to help them orient themselves, and that improve efficiency and reduction of costs as well that have come with that, and really help with empathy and mental health and psychological help. And in mental health, we see peer helpers who are models for other patients on the capacity to reinsert society and to become to help them with their problems, and it's a robust model even in training of these patients. But now we see this in other areas as well, and you'll be able to see it later on this afternoon with the hand clinic or other areas where we didn't think that we could use resource patients or helper patients. And we have some projects where there would be diabetes, renal issues, podiatry, and so how the patients, peer patients, and resource patients can help other patients in their care. So there's research that we need to do in the next years that we have started and that we're contributing to. So in terms of improving quality, as we said before, we did some evaluation work in terms of impact of the program for partnership of care, and we have helped patients, and we talked to patients and professionals to see see what their experience was and what they thought about it. The patients consider themselves full members of the team, so it has really a great impact on the objective. And there's also, they feel very privileged in contributing to the improvement of care, and they really have the impression that their experience is useful, and it really gives rise to them using their experience and feeling valued and have a better understanding of the issues in the healthcare and system and the complexity of the system they are in. So that really gives better communication with clinicians, and it makes it so that they're more available, and the meetings are not always at the right time for them to participate, and we make some adjustments there. And also they really talk about how things move slowly in terms of time, and the cultural shock where the patients come into a system and they hope things will move quicker, and it's solutions that seem simple, but it really is much more complex in reality. So I think the patients maybe can improve things time-wise so that things can move quicker. So in terms of the professionals, that's a really revolution to really realize finally that when we make a decision, it's important to orient it in terms of the lifestyle and the domino effect. Also, there's a lot of teams that are that have a lot of passion and that really positive and that bring other people in with them. And so another important thing is to really reinforce the cooperation between managers and physicians, and to help us to improve governance at the clinical level, and the patients also that give their testimony and help us to open our eyes and to see things differently, and to see a problem with the lenses of more realistic solutions. And it's really about the directorship of the patients in cooperation, and patients in cooperation with physicians, and to have really good management project-wise. And so we really learn with science and the engagement and participation of patients that it's not done just like that. We need resource patients, and to help them and train them, and to train them as a team. And the limit is the tools that we have, so that we can integrate things as quickly as possible. And the different difficulties in coincide. Recently, there's a lot of studies that have been published on the impact of patients on the quality of care. The last one that was published is the one I'm presenting here. There was 4 dimensions that were treated: the elaboration of criteria for quality, co-design, organization of process, quality committee, and quality improvement of projects. And so when we look at the 4 points, I was pretty surprised to see that there's a lot of studies that yet need to be done. We're still in a kind of a point of view where things are, or we say things are working, but the patients are not sufficiently trained. And so the resource patients said, so they try in a lot of ways to introduce new tools, but they missing a certain structure to be able to use them to their full potential. So it's really the message that we are getting, but they all see added value in all these areas as being essential, a different point of view and a different vision on things that can bring rise to concrete solutions and different ways of seeing things. So there's always everything. We'll talk about governance and management and user committees. That is an important part of the system in Quebec that has all this work to do for integration with the user committees and partnership with the patients. And there's this work to do in the next years. And there's also an extraordinary work that has been done in terms of energy. There's really a desire in terms of a project financed by the Canadian Association for Improving Healthcare, and to have research patients in all different levels and different areas. And so we're trying to put this project in place. And we can see in the beginning of this, and there's a recruitment of a patient that's in the room here for 2 days a week that really reproduces the model of the DCPP, but in the healthcare organization with a co-direction and partnership, and is really important, and a multitude of other actions where systematically patients are present. So what I think is great in the process of evaluation that we're doing is that it's a change in culture, a radical change, where the professionals are seeing that the patients have a lot of things to teach them, and they became dependent on the patients. So never again will we move without the patients. And so that's what we're seeing at the health and social centers in the different parts of Quebec. And so the Minister of Health right now is putting in place a policy, the last level that I talked about in my table, and it's a co-construction structure with the direction of quality and ethics have added, as asked for Vincent Dumais and Paul Lebel and other patients to be included in the discussion so we can really talk about the first co-construction of a policy in Quebec, I think, with patients, and so where we are evaluating it. In conclusion, I would like to talk about patient engagement at different levels, and that it really is not something we can improvise. It must be structured. And so when I talk about the lack of evidence, and so I'm going to talk about how we can build research and we can change the way we do things. So we have to really work right from the outset simultaneously between professionals on what the partnership with the patients means, the partnership, as we've seen in the University of Montreal, clinical practice and research also, so that we can co-construct together the evaluation of the project and the project itself and get to closing the gap and the having a bit of feedback and like in a living lab, and so they have a partnership that will be more effective and more human contact and will allow us to make sure the teams would be happy to work and take advantage of the experience and knowledge of the patients. So that's what I had for you today. Thank you very much.